I'm here to talk to you today about a piece of work I've been doing for about 18 months, I think, or just under, and it is a systematic review of surveillance for endometrial and ovarian cancer in Lynch syndrome. So I'm a systematic reviewer, which means I try and find all of the information on a particular topic, pull it apart, critique it, and stick it back together again, and hopefully give some kind of answer, which sometimes happens, sometimes doesn't. And in a bit of a spoiler, I'm not going to give you some perfect answer today. This study is is actually part of a study. It's part of a bigger piece of work that we've been doing at the University of Exeter. It's an NIHR-funded project that is looking at both the clinical aspects that I'm going to talk about now and also the cost effectiveness of the surveillance as well. So here's our team. This is our team for our overall study, the main study. So you'll see there's Tristan, who's actually in charge of the main study, the overall study, and I'm leading the systematic review that I'm going to talk to you about today. Nia is mostly working with Tristan on the cost effectiveness, although I did steal Nia for a bit to help me when I got overworked and needed some help. Kate Boddy is our PPI representative who helps us get patients and the public involved in our work. And Simon has been working with me on this systematic review and is also our information specialist, so he helps us gather up all of our studies. We're also part of a big project advisory group, and I'm not going to go through everybody on this slide, but you'll see some familiar faces there, or familiar names, and these are people who have been helping us and guiding us and keeping us doing our work on time and on target. So this is a bit obvious to most of you here, I'm sure, and we've heard today, we all know what Lynch syndrome is here, and we all know that it raises the risk of bowel cancer, and that colonoscopies are regularly offered so that polyps can be caught before they develop into cancer, and so that cancer can be caught as early as possible. But we also know that Lynch syndrome increases the risk of endometrial cancer and ovarian cancer, and surveillance isn't always offered. And we do know that usually the treatment of choice for this, for endometrial and ovarian cancer in Lynch syndrome, is actually to offer surgery before the cancers occur, so risk-reducing surgery. So we wanted to know why, there's lots of reasons why gynecological surveillance isn't offered, and one is it might not work well. We don't know that, and that's what we wanted to find out. It carries risks, it costs money, and also it might not be appropriate for certain people. So we wanted to give the best possible answer about how well surveillance is going to work. And we also wanted to know whether it'd be good value for money for the NHS, and that's more Tristan's domain than mine, that part there. So our overall piece of work had 4 parts to it. The first part being the clinical effectiveness systematic review, which is what I'm talking to you about now. But we also do have the other parts, the cost effectiveness systematic review, a systematic review of health state utility values, and a mathematical model. And I'm leading this first part, and Tristan is leading all of the other parts. I just wanted to say a few words about how patient involvement has helped us with this, because I think that's really important. It's been a key part of our whole project from the beginning. So right near the start, when we embarked on this project, we did a workshop and had patients come along to this workshop and help us shape what we were going to do, because obviously it's quite a big topic. We wanted to know what patients wanted to know, what they wanted to find out about surveillance for gynecological cancers. And it did throw up a few things that we thought were really important, and one was the use of general anaesthetic during surveillance. It also was clear that fertility was a key outcome that people wanted to know about, and also the impact of having gynecological surgery on colonoscopies. And HRT also came up as a really important thing that people wanted to know about. What goes on with HRT after you've had surgery, and how surveillance, and how does this compare to surgery or having no surveillance? We also did a second workshop really recently. So this piece of work I only finished it a couple of weeks ago, so it's super new. And a few weeks ago we did another workshop with patients to help us to work out how we're going to present all the findings from our project, and that was really useful too. And we've also had patients as part of the study team, as you saw on my slides earlier. As I said before, the idea of a systematic review is to collect all of the relevant information, all the research in a particular area that's been published in academic journals mostly, although we do also look at ongoing studies and try and find those as well. And I basically wanted to find out about the clinical effectiveness of surveillance, but also some more basic information, I would say. That's basically things like detection rates, how many cancers are being detected by the surveillance techniques, also the accuracy of the different tests, and also whether there are any harms to the surveillance techniques. One thing I will say is that the detection rates data and the accuracy data kind of came second to in our minds of what's important. We really wanted to look at the clinical effectiveness, and that is also what came out of our PPI workshops. Those were the most important things to patients. So when you start something like this, and there's so much information out there and you have to find it, we have to decide beforehand what we're going to include and what we're not going to include, and we make a list of criteria that we're going to use to decide whether to include a study or not. So basically we were only including studies, obviously, of adults with Lynch syndrome and who are at risk of gynecological cancer, so who still had the ability to have a gynecological cancer, so ovarian or endometrial cancer, so not people who had already had surgery. We also were looking for any surveillance, so I'm going to talk to you generally today about surveillance as a whole, and obviously that can be different depending on the study that we found. Sometimes it could include, most of them included biopsy, but some of them included a whole package of different surveillance techniques, and unfortunately in most cases they didn't break down any of the information by the different tests that were being done. It's mostly done as a package. We really wanted to look at studies that were comparing surveillance to something else, so preferably to surgery or to having no surveillance at all. And as I said before, we were looking at clinical effectiveness, detection, accuracy and harms, and we were basically looking for any study design, because particularly data on harms can be mentioned in any study. We were trying to find any information that patients could give us that was in the study. So this is what we did. We searched lots of databases. We chased studies, and that means we looked at a study and we looked at all the studies that study mentioned, and that's called chasing the studies. We looked at other systematic reviews to see what studies they had included to make sure we didn't miss anything. We also looked at the proceedings for conferences. That's when a conference happens and then all of the talks that were done are written up, so we had to look through those to see if there was any studies in those. And we also looked at ongoing studies that were registered. So we read 2,310 abstracts exactly. And when I say we, it's me and Simon. We both had to read all of them so that we could make sure we agreed. And actually that's not huge. It's not a huge systematic review. I've been systematic reviewing for 16 years now, and this is one of my smaller ones in terms of the number I had to look at that stage, but because we were looking for so many different things, I actually took quite a lot of time to look through to make sure we weren't missing anything. So we got 113 of these studies in full to look at them and make sure we wanted them, and out of those we wanted 44, but actually when we put them all together that came to 30 studies. I mean, some of them have been published in more than one paper. We did also investigate the overlap between studies, which is super hard to do because 30 studies sounds like a lot. And we wanted to make sure that actually it was 30 studies and it wasn't 25, but they were published more than once, and sometimes that's really hard to tell. And so we did try and investigate that, and it was really impossible. We looked at all the studies within one country and tried to compare them. We compared authors, but we really do think there probably is 30 separate studies there. We looked at the quality of all of these studies. We looked at their methods, we looked at what they did, we looked at what they found, and then we tried to bring all of that information together as best as possible, which was really difficult because all of these studies were so different from each other. So bringing them together was, I wouldn't say impossible, but really hard. So out of those 30 studies, 20 of them were single-arm studies, and by that I mean they only looked at surveillance. They're basically a bunch of people with Lynch syndrome who are undergoing surveillance, and that was often a historical database, so some kind of registry, and somebody had looked at the information that was already there. And we had 10 comparative studies, and these are the ones I really wanted, so because they can compare surveillance with something else. So in most of the cases, that was either with surgery or with no surveillance. We did find, I think, 3 of those 10 studies were actually looking at different surveillance, as in different time periods of surveillance. So the surveillance that was given changed over time. So those were less interesting to me because it was just looking at an older surveillance program with a newer one. It was the surveillance versus no surveillance I was mostly interested in. And here I put a little caution sign up, because what we always do when we're systematic reviewing is say, we look at the data, we really critically analyse it, and we want to say that just because there's a study saying something, it doesn't mean that this is actually true, and so we have to really look at whether it is or not. And the main thing to say about the overall information we found is that 20 of these studies are single-arm studies, and that they just can't tell us what would have happened if those people hadn't been on surveillance, so they're not as useful to us at all. I said to you that I'd pull everything apart and put it all back together. And with this, it was so hard to do because all the studies were different. And so really what we ended up with was a bunch of data that really I could pull apart and I couldn't put back together again to give a definitive answer. But so we started looking at key studies and studies that we thought were important. And we did find some data on clinical effectiveness that might be interesting. And again, there's the caveats that there's a lot of bias in there. We're not sure that these studies are particularly good. They're certainly not perfect. But we found some information that suggests that if we compare surveillance to surgery, that mortality is lower with surgery than with surveillance. And this was based mainly on one study that was conducted in Spain. And then when we looked at surveillance versus having no surveillance, we found that surveillance might be better than having no surveillance when it comes to both mortality and survival. And again, I wanted to look at whether that was actually the case. You know, there's just 2 studies there, there's not much information that are telling us this, and I wanted to just tell you the disadvantages of these studies, the things that make me be a bit dubious about those findings and stop me from being able to say definitively that surveillance is better than no surveillance or surgery is better than surveillance, and I don't think I can definitively say those things, and that's partly because this first study here, it was a study done in Canada. This is the one that was comparing surveillance to no surveillance. It used standard techniques, so it was really good in what it was doing. They tried to match the groups a little bit by trying to make sure that they were looking at a historical database, but they tried to make sure that the patients were matched on the fact that they were alive, which is always a good sign, and that they didn't have disease at the point where they started looking at the data. But it was actually quite a small study. The key groups that I needed to look at in that study only had 54 people in each group, and when you're trying to look at cancers occurring within a study that small, you're not going to get many cancers coming up at all over the period of time they looked at it. So it was a small study, and they also didn't mention what any other differences were between the groups, and it's likely that there's some kind of bias in there and that they differed in lots of different ways, including the family history and the likelihood that the control group had a stronger family history of previous cancers than the other group, than the surveillance group. The other study, the one that was comparing with surveillance, was relatively large in one of their samples. They had 465 people having surveillance, but it was smaller for surgery, only 66, so there's an imbalance there. And there was no biopsy, so that's a disadvantage when biopsy is usually used. And also, the people who had surgery were people who had previously had surveillance. So they weren't looking at people who had never had surveillance and dividing them into surgery or surveillance. They were people who had had surveillance and then opted to have surgery, which obviously muddies the waters a bit. And again, we don't know how these groups differ. They didn't provide any information really in the paper that would tell us whether there were any differences between these groups at baseline. So that gives you an idea of what we were working with. We were working with information which at face value looks like it's giving us an answer, but actually when we delve deeper into the studies, it was much more complicated, and we probably can't say for sure whether anything's happening with the surveillance that's useful. We looked at the cancer stage because we thought that was a really important thing to look at, because I suppose the really important thing to know is whether cancers have been detected earlier than they would be with surveillance than if surveillance wasn't happening. And one way we did that was to compare the cancer stage at surveillance for cancers found detected with the surveillance with ones that were diagnosed between the surveillance visits, so ones that they're called interval cancers. And basically, there's very few studies that reported this, and of the ones that did, there was few cancers, and then when you break that down further into stages, there just wasn't any clear information that could answer that question. And we also wanted to look at whether cancers detected when you compare surveillance to no surveillance, whether there was a difference in stage, and we only found a really small amount of information on that from one study that suggested there might be detected earlier with surveillance than without surveillance, but again, the study was really tiny, and we couldn't really make any firm conclusions based on that. So we also looked at fertility, which was one of the key things that came out of our PPI workshop that everybody wanted to know about, and obviously we didn't need to or expect to find any data comparing fertility, so whether people go on to have children. We weren't expecting any studies to be looking at surveillance compared to surgery, because obviously surgery is going to bring a natural end to fertility anyway, so we weren't expecting that. But we were hoping we would find some data for surveillance versus no surveillance, just some information about whether people went on to have children more if they had surveillance than no surveillance. And we found absolutely nothing. It wasn't mentioned in any of the, so there's 30 studies and it just wasn't mentioned. And I think that's actually quite an important thing, that this is important to patients. It came out in our PPI that it was important to patients, but it wasn't literally not mentioned at all in any of the studies. So this slide is just to summarise what I've just been talking about over the clinical effectiveness of the study. So that's about deaths and survival and fertility, and as you can see, the picture is really woolly. We didn't find out very much apart from that small bit of information from those two studies that were probably flawed, that told us that maybe surveillance is better for mortality and survival than no surveillance, and worse than surgery. But we have to be really cautious about this, as I was saying. So we can move on to talking about the detection of cancers. So we looked obviously at endometrial cancer and ovarian cancer separately, and luckily that is what the studies did as well. They didn't just say we found this many cancers, they were very specific about what types of cancers they found. So that was easy for us to separate out. And we wanted to know how many cancers were being picked up by surveillance. And the really key thing that stood out to me was that there were lots of studies. Out of these 30 studies, there was about a third of them that were not detecting any endometrial cancer at all across their study period. Now, obviously, that's going to differ depending on how long the study was. If it was a really short study, you wouldn't expect many to be detected. If it's a super long study, you would expect them to pick some up. But these studies ranged from, ones that only had one surveillance visit, so were like 1 year long, 2 years long, to ones that were looking at historical databases that spanned quite a wide range of time, and still many of them found no endometrial cancer at all. Again, this could be because the samples were small. Amongst the other studies that did detect some endometrial cancers, the rates of endometrial cancer varied from 0.8% of the people in the study to 7.3%, but I have to say most of them were closer to that lower end of the data. There weren't many that were kind of over 4%. So I'm sure, as you would expect, if we didn't find many endometrial cancers within the studies, the ovarian cancers, the data was even lower. There was even lower rates detected. We had fewer studies that reported endometrial cancer at all. Some of the studies were only looking at endometrial and not ovarian cancer. So very few so there were some that didn't mention ovarian cancer at all. And of the ones that did, quite a lot of them didn't detect any ovarian cancer at all as well. So there was only a handful of studies really that actually detected ovarian cancer. And the rates were lower, as you can see, from 0.1% to 3% across the studies. So really quite low rates if we're thinking about some of these studies that went on for quite a long time. So for both of these, for both endometrial and ovarian cancer, a lot of this data is from the single-arm studies. It's from the studies that only have surveillance and don't have it, they're not comparing it to anything. So I wanted to look at this key study, this study that was done in Canada, because this actually had some information that was quite interesting. If you remember, I was saying they showed that mortality was lower and survival higher in people who had surveillance than no surveillance. And it was quite interesting to me and quite unexpected to me that they found lower rates of endometrial cancer with surveillance than without surveillance. So I was wondering why that would be, and I think to me it points to there being some bias here in the study. I think what's happening in this study is there's some imbalance between the groups at the beginning here. If you see these first two boxes, there's some things acting on these samples, some differences in the samples that are probably creating an effect as we go down. So I think these differences within the samples are then meaning that more cancers are being detected in the people who didn't have surveillance, and that is likely because they are different, so more likely, like I said earlier, to have a strong family history of cancers or other reasons which are just unknown at the moment because they just provided so little data about the samples. So there's something happening there which is making more cancers within that group, and then that obviously is going to lead to more mortality and poorer survival within the group. I've got some acronyms there which I should tell you what they are. ACM is all-cause mortality, that's mortality due to anything, and then we've got endometrial cancer mortality and ovarian cancer mortality. So this kind of helped me to kind of, in my mind, think that, yeah, something's going on here with this study that's not quite right. There's some bias here that's making us have this result that at face value would have made us look at immediately and say, oh, look, surveillance is doing much better for mortality and survival than no surveillance, but these cancers detected made me think about it a bit more. So we wanted to go a bit further then and see whether surveillance was detecting asymptomatic cancers, because obviously that's one thing that we can make an assumption about, that is the asymptomatic cancers that would be less likely to be detected when you're not having surveillance. You know, they're the ones that we think surveillance might spot that you wouldn't otherwise be spotted. So I had a look to see how many of the cancers that were detected were asymptomatic, and in 4 of the studies they were all symptomatic. And in 2 of the studies they were mixed, and in 6 they were asymptomatic. So it didn't tell us much at all looking at this, unfortunately, other than surveillance is detecting some asymptomatic cancers. It is doing that. So we could make an assumption that it's detecting cancers that wouldn't otherwise be detected, but I'm not sure that's a totally safe assumption to make, because firstly, we don't know that. There's no studies actually comparing to no surveillance. And secondly, we don't know what the impact of that is. We don't know whether the asymptomatic cancer might have become symptomatic shortly after, and then what the impact of that would be. Would the actual outcomes in the end be different if, for those? And there was no information on that at all. So the other thing we were looking at here was missed cancers, and those are those interval cancers I was talking about, and we wanted to see how many of those were happening. We wanted to know if surveillance was missing cancers, that were there. And interval cancers are the best way for us to look at this. And this was reported in most of the studies actually did report the interval cancers. So there was quite a lot of data. Not all of them reported it, but most of them did. And 8 of the studies showed no interval cancers at all, which you might think is great news, and they're quite low, but I'm not sure that they were all clearly going out of their way to report this data, to pick it up and to report it clearly, but it does suggest that surveillance has been picking up most of the cancers, or at least most of the cancers that we know about. I put in a couple of slides about test accuracy because it was something that we did look at in this study. We were looking at whether the individual tests, so I was talking about surveillance programs as a whole, but then we also wanted to know whether the individual tests were accurate at predicting cancer or not. It was something we generally do when we're doing this kind of work. To me, it's slightly less important, but it's been quite topical, this whole, are diagnostic tests accurate with the whole COVID thing. We've all been doing our lap flows and we've had PCR tests, and we hear in the media about whether these tests are accurate. We've heard, some of us might have heard the terms now, sensitivity and specificity, and what that means. And we were looking at that for the test. So the sensitivity of a test in this context is the extent to which the test detects cancers as positive, so cancers that are there and actually detects them as positive. And the specificity of the test is the extent to which the test detects people without cancer as negative. And as I expected, there was few studies that actually reported this information. It was usually a secondary outcome or tertiary outcome in the study, or was mentioned in a sentence somewhere, and there was only 5 of them that did, and only 3 of them actually were really clear what they were comparing the test against. Some of them were saying the sensitivity of the test is, and didn't actually even say what they were comparing it to. And there's 2 studies that I don't think are particularly informative, but I put them up there for you, showing the sensitivity and specificity of one of them for pelvic ultrasound and one of them for hysteroscopy, both comparing or using biopsy as the standard thing to compare to, which I don't necessarily think is the right thing either. So I'm not sure that these were really informative at all. And unfortunately, what I really had wanted when we decided to look at test accuracy was some nice data that would show us the comparative accuracy between more than one test against a really good reference standard. So histology that was done on tissue samples that was really quite definitive, and then more than one test being compared against that, but we didn't find that. So this, to me, the harms of surveillance was actually one of the most interesting things that I was looking at. We know that surveillance could lead to a number of harms. We know those most likely harms of surveillance techniques are pain and bleeding and infection, and obviously this differs depending on what tests we're looking at. Most of the information we wanted to know about was what was kind of survey-based data, what patients were finding, how they experienced the harms, and how and who, and also who. Like, so do some certain groups experience them more than others? So these were our questions here. I just want to say, like, when I talk about a lack of data, which I've done all the way through this, there's 30 studies, but a lack of data. But particularly here when we're talking about harms, I just want to make it really clear that just because the data isn't there, it doesn't mean the harms don't occur. Like, a lot of the studies just don't report this information or haven't sought to do it, and we only found a couple of surveys that were actually specifically looking to answer this question. The rest of the information was found within studies that chose to report this information. So almost all the data we found on harms was about pain, and it was almost all about biopsy pain, and it was all of that biopsy pain data was about PIPEL sampling. So it seemed that overall, so this was something I did manage to kind of have a good look overall, and almost all of the studies used some kind of scale, 10-point scale, 11-point scale, 5-point scale for patients to rate their pain, and almost all of the pain ratings given by the studies were somewhere in the middle. So it was moderately painful for people, but the range was really wide. So you had people that were just, it's not painful at all, and people who found it absolutely, I'm just not doing this ever again. So it was a really wide range, but generally people were somewhere in the middle. We did find one study where people who opted for surgery reported lower biopsy pain than those who kept having surveillance. So it was a survey, and they were asking people their biopsy pain, and the biopsy pain in people who went on to have surgery was reported differently to those who kept having surveillance. And I thought that was quite interesting, but I do also wonder whether it's just an effect of how long ago it was that they had the biopsy. So if they've had surgery, the biopsy was likely to have been much longer ago than if they hadn't. We also found that there's some evidence that biopsy pain affects the decisions that people make about surveillance, whether to have surveillance or not. And again, this was a really small amount of data, but kind of qualitative type data. So it was survey data, quantitative surveys, but some comments on patients that were saying that they didn't want to continue with surveillance, or they wanted to stop surveillance, or just actually at the surveillance visit, or they just didn't want to keep going with it. And perhaps even opt for surgery. We found a few studies that talked about managing pain and how people manage pain for their biopsies. And one study reported that the non-steroidal anti-inflammatories were used, so ibuprofen usually, before surveillance, so people were taking this before they went to their surveillance visit. And this seemed to increase from... There was a study that showed that at the first visit, there was about 21% of people were taking ibuprofen before they went. By their fourth or fifth visit, it was 80% of people were taking ibuprofen before they went. So that can indicate to us they were finding it painful, although the sample size was also going down over these visits, so it was really tiny at the end. But I thought that was quite interesting. So people are generally finding it painful and perhaps dropping off because it's painful, and perhaps taking ibuprofen more because of it. So it seems to be the experience that people are having. And we also found a survey that's based in the UK. This was Neil's paper that suggested that almost a quarter of people who had hysteroscopy received a GA, which I was surprised at. I thought that was quite high, but that's what came out of this survey. So I said we wanted to know if pain was different for different people, for different groups of people, and there was a small amount of information that we did manage to pull out about pain for different people. There was 2 studies that showed that postmenopausal people were had higher pain than premenopausal people. And we also found 2 studies, not the same studies, but 2 studies that showed that people who hadn't had children, so who hadn't given birth, were more likely to report higher biopsy pain than people who had. And perhaps both of those are unsurprising. And they also, one of those 2 studies also reported that people who had a C-section reported higher pain than those who'd had vaginal delivery, which also I suppose wouldn't be surprising. And people were really concerned about pain, and they were really concerned about fertility as well. So there was a lot of concerns about surveillance that were reported in the papers. And one study found that there are few participants who were concerned about the effect of hysteroscopy on fertility. So in this study, 3 participants just didn't want to take part in the study at all because they were worried about their fertility being affected by hysteroscopy, and the 2 out of the 24 participants who did take part in the study declined the hysteroscopy part because, as I said, there was lots of tests within each surveillance program, but 2 out of the 24 said I'm not having the hysteroscopy because they were concerned about fertility. And these are just a few cases, and we're talking about small numbers here, but also we know from this that these concerns do exist. They are there, they're out there, and patients are having these thoughts. So the main conclusions overall was, for all the parts of this review, was that surveillance may be better than no surveillance and may be worse than surgery at reducing deaths, but this really is unclear, and I don't want to definitively say that at all because of the issues I was talking about with the studies. We know that surveillance doesn't detect a huge amount of endometrial cancer or ovarian cancer. It does detect some. It does detect some asymptomatic cases, but it does also miss some cancers too. We know that biopsy is moderately painful and it can impact whether people want to have surveillance or not. And we also know that people might avoid hysteroscopy and need general anaesthetic quite frequently. So in terms of this review, we don't have a clear-cut answer, and I think we need some better data, we need some better studies, and my first thought was we need to plan some new studies, some nice prospective studies. They're studies that start from the beginning and look ahead, and they compare surveillance with no surveillance, and they do it all as perfectly as I would like them to do, so that when I'm critiquing them I can't find anything wrong with them. But I also wonder if that data is there. It's possible it actually is there in some of these databases. It just hasn't been looked at or reported in the way I would have liked, and I can't tell you whether that's the case or not without having a little look myself or having somebody who's much better at maths and stats than me have a look at it for me. I can't answer that. So it could be that information is out there somewhere, but we just haven't pulled it together and looked at it in the way that we want to. So maybe we need a new study, maybe we need some big studies, but maybe we don't. So thank you, and I just want to also say thank you to the review team that I showed you pictures of at the beginning, the clinical experts that have been helping us, all our patient experts, and our PPI representatives and clinical experts, and also to say that I did stole some of these slides on Tristan. The first few slides that were introducing the project were Tristan's and not mine.